Welcome, colleagues and friends. It's a real thrill for me to be able to host today, day 2 of TIO. We had an amazing day 1 yesterday and have a lot in store for you here today in the complex PCI and high-risk PCI space. We're going to have 2 sessions today. We focus first on calcified coronary artery lesions, and then we also talk about chronic total occlusions. In between, we have interspersed talks on multivessel disease, staging, and the like. And remembering, this format of TIO is very interactive, so short talks followed by longer discussions that'll hopefully touch on all the germane points relating to these topics. We also have 2 concurrent live cases. We have Mount Sinai Hospital transmitting for the first time to this meeting, also Leipzig. That's the calcified sessions. Then we have a break, which will undertake a comistrenal alignment case, as well as 2 other breakout sessions on coronary physiology and STEMI, and also just innovations in treating complex PCI. We then move to an afternoon session dedicated entirely on the CTO space with some didactic talks, as well as live cases from our colleagues in Erasmus, and also myself and Dr. Mark Entegard from New York Presbyterian Columbia. So without any further ado, let's go ahead and get started with a super exciting day 2 live for TIO. Well, welcome to day 2 of TIO, and we're going to start our session on complex coronary disease and severely calcified lesions. We have an amazing panel here today. Zim Latib, my friend and colleague from Montefiore Medical Center, Yus Damon from Erasmus, Didier Cheche from Clinique Pasteur in France, and my good friend and colleague Margaret McEntegard, who is now going to be leading our complex PCI program at Columbia New York Presbyterian. Great talks, great discussion coming up, and we're going to open this with a poll question for the audience, really trying to focus on imaging and the utility of imaging. So if we can have that poll question first, we'll go to it, and hopefully you'll be able to comment during the course of this session. The live polling question is, do you agree with the following statement? Imaging is essential to select the best management strategy for calcified coronary lesions. Simple yes, no. I know we're going to have a lot of discussion on this topic, but it'd be really interesting to get your feedback and what you think about this specific question in your practice. So with that, just feel free to take some time to answer that question as needed, and please submit a question response on the poll tab on your screen. So let's start our first presentation, where we're going to be joined by Joost, who's here from Erasmus, and is going to talk to us a little bit about this topic, invasive imaging appraisal of dedicated calcium modification techniques.
Thank you for the introduction, Ajay. So I will talk today a little bit about invasive imaging appraisal of dedicated calcium modification techniques. So as you all know, angiography is only moderately sensitive for the detection of calcification with a sensitivity of 60 and 85% respectively for 3 and 4 quadrant calcification respectively. And with that, it is important because the presence of calcium is associated with difficulty to deliver devices, poses the patient at a high risk of dissections and hematomas. is associated with longer procedural times, an increase in resources, hospital stay and cost. And with that, there's a likelihood of ending up with stent under expansion or small minimal stent areas that have been consistently proven to be the most important predictor of stent failure. With the use of IVUS and OCT, conversely, you can get a much better appreciation of the severity of coronary artery calcifications. So with IVUS, you can very easily appreciate the arc and the length of the calcium, whereas with the use of OCT, you can appreciate the arc and the length, but also the thickness, the area, and the volume of the calcifications. So then the key question is, before we start talking about how do you identify certain patterns of calcium modification, I think it's important to understand how you identify severe calcium by OCT and IVUS. And with that, it is important that we look for the angle of calcification, the thickness of the calcium, and the presence of nodules. And with that, you can argue, so what is then severe? Well, in that case, we've several cutoffs that I think should be important to consider. One is the angle of calcium, which is at least 180 degrees for OCT and perhaps a bit larger, 270 degrees for IVUS. The thickness of calcium, if the thickness on OCT is above 0.5 millimeter, that is considered to be severe. Or on IVUS, obviously the appreciation of the thickness is much more complex. So you can rely on the presence of a reverberation arc, which is associated with thinner calcium. Obviously not as sensitive as OCT, but a marker that you could use to assess the thickness of the calcium on IVUS. Finally, the presence of nodules is identified as a consistent predictor of severe calcification, and then it's important to look for the length of the calcium. So longer than 5 millimeters is associated with more severe and more complex calcium, and also the vessel diameter is of importance, with diameters below 3.5 indicating severe calcification. So with that, if you've done all that, you can use all kinds of different algorithms to select any particular type of lesion modification strategy, ranging from balloons, cutting, scoring balloons, or atherectomy. It's beyond the scope of this presentation to tackle that, but what I do believe is important is that everybody learns to understand how you identify the severity of calcium, and even perhaps more importantly is how to identify that you adequately prepared the lesion. So I will tackle some of the most used technologies to crack the calcium. And with that, I would like to start with POBA, so the plain old balloon angioplasty. And with that, I think it's important to understand the key principle of POBA. So, and that I think is very nicely illustrated by a presentation, or actually publication from from our Bernese friends, indicating that if you have eccentric calcium, as shown here in the OCT picture on the left, the balloon will rupture the vessel wall on the side where there is the least amount of calcium. So in this case, you see in the middle panel a little dissection just on the opposite side of the vessel wall, which is exactly the spot where the resistance is the value of the vessel is the lowest. In case of more concentric calcification, it's very clear that if you have thin calcification, the balloon will probably rupture the calcium, as you can see here in the mid panel, meaning the resistance is gone and you can safely proceed with stenting. In case of very thick concentric calcifications, and this I think is where imaging makes the difference, if you have calcium that is above 0.5 millimeter, you do your ballooning with a high pressure non-compliant balloon, you would repeat the imaging. You can very nicely appreciate that here in this figure the balloon simply didn't do anything. No dissections, no cracks, no hematomas. So in these cases people should probably refrain from stenting. So on the right side, also a live example of what happens if you dilate eccentric calcification. So you see a thick calcified plaque of around 90 degrees at the bottom of the vessel here, whereas on the other side you see a nice dissection on this high definition IVUS with a small hematoma on the back side, indicating that the resistance is out and you could proceed with stenting. Here are some more examples of thin calcium. You can appreciate that by the fact that there are some reverberations here. Concentric, but probably not that thick. If you do your ballooning, you can nicely see here at 2 o'clock you see the cracks arising. Here you see it. And here again, thin calcium, you nicely see the reverberation arc, and following ballooning you very nicely can see the cracks here and the dissection on the opposite side. Whereas in this case, where you have thick calcium on IVUS, you see no reverberation arc, and what you do see on the right is that this calcium nicely yielded with cracks and dissections all the way around the vessel. Again, of particularly important to always repeat the IVUS after your lesion preparation, whether you use rotablator, orbital or ballooning, because the dissections you create will extend. And this is a nice image of around a segment of around 20 millimeters, in which you see extensive dissections and hematomas all the way ranging from the distal to the proximal part of the vessel. And this will finally identify your landing zones of your stent. So if you do some aggressive ballooning, repeat the imaging, because only then you will be able to appreciate proper and healthy reference segments. Moving on to coronary lithotripsy, based on unfocused energy created at the emitters in a fluid-filled coupler generating a steam bubble, and that creates sonic pressure waveforms. Very nice example here of an OCT image of a mid-LAD with a thick concentric chunk of calcium here in this mid-LAD, MLA of 2.19. Here you see how the steam bubbles look in this gel model. Calcium here all the way around 360 degrees, MLA of 2.9. And if you do your shockwave and repeat the imaging, you can see a beautiful example how the shockwave can tackle the thick concentric calcifications with clear cracks on the OCT, with the lumen area that clearly improved, and allows the implantation of stents. So with that, shockwave proved to be an appealing technology for thick concentric calcification, also for deeper calcifications, perhaps even useful for instant use and even for nodular calcifications, for which recently some interesting data appeared, but perhaps a bit less appealing in very long lesions with calcium of segments of 50 millimeters limited to the balloon length, meaning that you would need probably a lot of balloons in order to tackle that. Then moving on to rotational atherectomy, completely different technology. So you know, everybody knows, Azim will talk about that in a few minutes. Rotational atherectomy in patients with highly calcified nodules. Here a case example of a osteorite with a very tight calcified lesion. You can see that on the left image. The operator in this case attempted some ballooning first because of some reluctance to use the rota, but fortunately here the imaging was repeated, and you can clearly see that following a 2.5 non-compliant balloon, this nodular calcification, which you can easily appreciate here at 9 o'clock, did simply not yield, with a minimal lumen area which remained around 1.2 millimeters. On the right side, however, what you can see what happens after the rota with a nodular calcification that clearly is cracked now with the MLA that clearly improved to 3.5 millimeters. Orbital atherectomy, completely different technology based on pulsatile forces that also may affect deeper calcifications, and the concept of sanding. How that looks in OCT, we've recently explored after being the first in Europe to test this new technology. You can see the sanding concept with some superficial sanding here and superficial calcification. You can find deep medial fractures, and even in nodular calcifications, you can nicely see that after the orbital atherectomy, this nodule simply becomes smashed and allow the subsequent stenting of this vessel. Final slide, again a right coronary artery with significant calcification here, easily to be appreciated on the OCT. Thick calcium here, concentric, very small lumen area, also here proximally concentric calcifications. We did several rounds of orbital atherectomy. The good thing is that distal in this vessel, you see that the vessel is nicely intact, but in the proximal part you can also see that it's sometimes very difficult because the intima might get damaged, you get a little bit of thrombus. So it is sometimes difficult to really appreciate all the cracks, but the key message here is that you will learn from doing as more and many pullbacks as you can, because only then you will clearly learn to appreciate the individual calcium modification techniques of all these individual tools and techniques. So with that, I would like to conclude by making one statement, and that is perhaps also the answer to the poll question. At least to me, intravascular imaging is the key to confirm successful lesion preparation. Thank you.
Well, thanks so much, Joost. There's a reason we asked the poll question before your talk, because we want to see what people say before they're influenced by it. It was a fantastic overview. A lot of good pictures, practical points, and we have about 9 minutes for discussion. So I want to pose this to the panel, and the first is that more and more at these types of conferences and on other types of venues, you'll see imaging being presented. And yet, if we look at the overall rates of imaging worldwide, they languish far behind what we're seeing and showing in these venues. So first question, maybe for you, Azim, is how do we get more proficiency? And do you feel that imaging is essential for the management of these complex cases?
Yeah, great question, Ajay. At Monty, before I arrived, I think we were using imaging in probably pretty high, about 20 to 30% of cases. It's now 90% of cases, 80 to 90% of cases, because the whole team, the more they use it, the more they've become convinced that it's not needed just for complex cases, it's needed for all your cases. The problem is, how do we spread that to the community? Because in the US, where there's some reimbursement, it's a little bit better. In Europe, it's under 10% in single digits. We have so much clinical data. I think a lot of it is just, I'm hoping it's the younger generation. All our fellows, when they leave Monty after their fellowship, go out and believe that imaging is the way to go. And I love when I now show a case to one of my fellows and I say, what would you do here? He goes, I need to see the imaging. I need to see the intracoronary imaging. I need to see the IVUS. I need to see the OCT. So I think we just got to keep at it, because the data is there, but we just got to keep spreading the word, keep teaching the younger generation. Hopefully they will do better than is being done currently.
Oh, that's great. Didier, maybe it's for you a question on imaging modality. How do people pick which one to use, and do they start with one and become proficient? What should people do when they're trying to go out and do this? Because we want to keep this very practical.
This is a very important point, AJ. A very important point, and I do believe that for the fellows, they should try to master every kind of imaging modality, because they are complementary. And I would say that for osteal lesions, I do believe that IVUS has an advantage, because you can clearly identify the osteum of for instance, the left main very easily, or the right coronary artery. And you need to tailor the type of the imaging modality that you're going to use to the patient. And for instance, if you have a patient with a decreased renal function, potentially IVUS once again could be useful, because you minimize the amount of contrast. So I would say, first, let's try to become extremely proficient with one of these modalities, but as soon as possible, learn the other one, because they are both concur to the success of the PCI.
I think that's a super important point, and the idea here is to become just complementary in your skills of PCI as a whole, and viewing each of these as a different tool, and specific tools are needed for specific tasks. Maybe, Margaret, tell us a little bit practically. You spoke a little bit provocatively about when you do imaging runs. How many imaging runs do you think are necessary? And is it just to select the modality of what you want to do, or is it to look at final stent results? How do you use it practically?
Yeah, so I think ideally you should use imaging at each stage of your case. So if you can cross as early as possible in the case, depending on how critical and how severe the disease is, I'd suggest you image either right at the beginning or after your first modification. I think you then should image again to assess your modification, as you just demonstrated really nicely in those cases he presented, and to ensure that if you're going to go on and stent, that you're going to get a good stent outcome. And then finally, obviously, to perform imaging at the end to assess your stent outcome. I think sometimes there's a behavior of using the imaging at the end, essentially to kind of validate your result, but not using it during the evolution of the case. So I think really to learn more about what you're doing and to ensure that you get the best outcomes, I'd suggest the image at baseline, post-modification, and again at the end.
Yeah, I think that's exactly right. And Joost, tell us a little bit about how you implement this in your practice, in your lab, because Erasmus is known for its imaging program, and not just new technologies, but cutting edge technologies, but in practical day-to-day life. Azim talked about going to 90% of cases. How do people implement this if they're just starting out?
Yeah. So what I think is crucial is that the imaging you never do alone. I think you need a team and a proper setup to get it easily implemented, and to make it attractive to be used on a daily routine basis without bothering the staff. Oh, well, you have to bring in the car to do the imaging. And our staff in our lab, we spend a lot of time and energy in training the nurses, training the technicians. We have our OCT and IVUS equipment completely built into our CAT lab, meaning that the setup for a IVUS or OCT procedure is less than a minute. So that makes the threshold to use or to decide on the usage of imaging very low. That is one thing. Second is that the one who's operating the console and is doing all the measurement needs to be familiar with the console, familiar with the buttons, and familiar with the image interpretation, because only then you can have a proper communication between the operator and the one who's handling the console to make it swift and efficacious. So to that, I think that the bottom line here is training. Training not just for the operator or the fellow, but for the full staff who is helping to assist the case.
No, that's great. I think we're going to leave the next talk to Azim, and we have still about a minute and a half of discussion. Didier and Margaret, maybe let me ask you, we have some big imaging trials that are going to be coming out relatively soon and enrolling. Do you think those trials should just be confirmatory? Does it really matter what the results are, or should people already change their practice, or do you think the trials are super essential and important? Because I think that hopefully the trials will be positive, but what if they're negative? Well, how would you go about talking about this? Maybe Didier?
I think it's always about experience and daily practice analysis, and we've seen from several years that the use of imaging is really crucial, particularly when it comes to complex multivessel coronary artery disease, calcium being one of the toughest subgroup of patients that we need to treat. And we've learned that imaging is crucial in achieving good outcomes, immediate outcomes, procedural outcomes that are going to correlate to good clinical outcomes for the patient. So even if these trials were negative, I don't think that it's going to change the practice. The trend goes towards an increase in the use of imaging for complex PCI, and it's going to remain, to my opinion.
Yeah, I would agree, and I hope we're never in that situation. I do hope they're super positive, and then we can really, really drive home what we need to do. Margaret, any final thoughts on implementation of this? Do you see this changing? Is it slowly changing fast? What do you think?
Yeah, I think it's changing much like you said. In our lab, we had a new batch of consultants that came in the early stage of their practice, and they were all highly convinced by imaging. So we've seen our imaging use going up in my previous center from probably about 10% to 50% in a very short period of time because of the change in the generation of interventional cardiologists in the lab. So I think it will change, but it will take some time. And I think, again, just as was previously discussed, I think empowering the room and getting the staff interested in imaging, once people are interested in it and they understand what the purpose is, then they'll drive the enthusiasm for you to use it in the cases.
Yeah, that's fantastic. And I think Azim's going to teach us, not only what to do with when you have imaging, but all the tools are disposal to treat calcified lesions. And so with that, let's hand it over to you. We'll hear a talk and then come back for some discussion.
Great to be back at day 2 of TIO, and thank you, Ajay, for the introduction. I think my job's been made easier by yours to, really show some convincing slides of how the toolbox I'm going to show you works in calcified lesions. But hopefully, I can share some of my own experience with you of what I use in my toolbox on a daily basis. Next slide, please. These are my conflicts of interest. Well, when we talk about complex PCI, there's really a lot of different anatomies and patients that fit into complex PCI. But I'm really going to be concentrating on those with heavily calcified disease, which I have to admit, is becoming a larger and larger part of my practice, particularly here in the US, but also I think worldwide as our patients become older. Why do we talk about calcium and make a big deal about it? Well, there is clinical data. This paper from Philippe really shows and highlights how calcium significantly increases procedural complications. It's an independent predictor of adverse clinical outcomes, including TLR and MACE and MI. But when in the cath lab, it really impacts what we do. It makes stent delivery challenging. We end up with malexpansion, asymmetry. There's certainly increased procedural complications because we get more dissections, more perforations. We try and push devices to get through these calcified lesions. They don't often respond in a predictable way. And we've seen increased stent thrombosis and restenosis with calcified lesions. So when we think about our decision-making, about devices and strategies in our toolbox, it really is multifactorial, and we need to take a number of factors into consideration. And maybe this is one way of looking at it. Well, certainly the characteristics of calcium. We saw that from yours presentation, the arc of calcium, its thickness, its depth, where it is extremely important. But also other characteristics related to, for example, the lesion, the vessel size. Is it a small distal lesion we're trying to treat versus a large proximal lesion? Is it an osteal lesion? Is the vessel tortuous, or is it a bifurcation? These will all impact all the different, or how we'll use our toolbox in order to be able to decide how to treat that complex lesion better. And then also the devices. These devices that we'll use, and we'll see briefly now, work in a different way. For example, if we think about debulking with atherectomy, really wire bias can have a huge impact. In the case on the left, where you see the wire is biased far away from the calcified lesion, you can go down this lesion with atherectomy as many times as you want, it may not have an impact. Whereas a favorable wire bias will have a large impact. So these are all those considerations that come into mind. One of the things I still, I think I have a challenge with, and I see people saying, is how do we assess calcium? We look at these two angiograms, and they both look like severely calcified lesions. But again, highlighting what you'll hear over and over in presentations and from experts is that most of us, even though we may think we're really good at evaluating calcium, actually can't do it very well angiographically. And imaging allows us to know and see better what we can do. So this lesion, yeah, absolutely, severely calcified. This one here on the right that looks very calcified in angiography, actually when you do imaging, the calcium is all more in the adventitia and is not going to impact stent implantation. But would we know that without imaging and without looking into the artery? I think not. And that's kind of why I think it's so important. I also think that knowing the type of calcium you're dealing with really impacts your toolbox. Whether it's deep calcium, you may just be okay with scoring balloons because the calcium is not going to impact you. If it's more superficial, laser or lithotripsy, orbital atherectomy, and then nodular calcium, which is the one I find most challenging to treat, is usually better treated with atherectomy. Well, what's in our toolbox for calcified lesions? I think when you think of your toolbox, it starts from the beginning. It starts with support, knowing your guiding catheters, guide extensions, microcatheters, and wires. Also, will you need mechanical support during that case? What about angioplasty? What kind of balloon will be best to treat that lesion? And yeah, I'll hopefully go quite quickly because I think US covered a lot of that. And then do we need atherectomy and debulking? And which device will work better in your patient? So when we think about support, it's really, I think for calcified lesions, starting the case well results in better outcomes. And too often I see people struggling with the calcified lesion because they started poorly. They struggle through the entire case because they don't have good guide catheter support. They're not making proper use of guide catheter extensions. Or cause injury with guide catheter extensions. And also, there may be other techniques that may help you to improve your support, such as using anchoring balloons. Balloon angioplasty, besides non-compliant balloons, we have a lot of other balloons. You saw some of those with used. I wanted to highlight a couple. I think high pressure balloons, such as the OPN balloon, is a really useful adjunct for some cases. This is now going to become available in the United States as well. We don't have this currently, but I think will be an interesting adjunct to what we do. We also, many of us like using cutting balloons, particularly at high pressure, because it gives you an undersized cutting balloon at high pressure can give you really good uniform expansion, and better expansion, other than just cutting, can give you very good expansion that's uniformly transmitted to the wall. We've talked about lithoplasty and lithotripsy. I think we're going to see more lithotripsy devices that all do the same thing. They emit a spark, it interacts with contrast, creates an acoustic wave that moves through soft tissue and only impacts with hard, rigid tissue such as calcium. We don't really need to talk much about this because you saw some amazing pictures from UST about how this really works in patients and affects calcification. So I'm just going to skip this to the next slide and move on a bit. But what about atherectomy? I think the lesions that are most favorable for rota, which is what I use the most, are those that are concentric, superficial, with a smaller lumen diameter, and are thinner calcium. And really, it's all, again, imaging that helps you use that. I'm not going to talk about burst size selection, Y bias, or device manipulation. I think we can talk about that in the discussion, but those are all important factors to think about when you use rotablation. We now have in Europe and in the US, both rotational and orbital atherectomy. There are differences between the two, which we can discuss during the discussion. There may be certain types of vessels and calcium that do better with one or the other, and certain diameter of vessels that do better with one or the other. There is data on both, and RJ is very involved in the randomized clinical control trial, but we do have some data showing that there's really no significant differences between the two from a systematic review and meta-analysis. And then the last one I'll just briefly mention, and I'm going to stop, is MCS. I think you do need to know when to use mechanical circulatory support and what will help you best in treating your patients. Most of us in our more complex cases have moved to using impeller. I rarely use balloon pump. I think you need to know what the contraindications are and essentially, have an algorithm for how you use it. But in patients, the high-risk patients that I use are very similar to in this paper, with low ejection fractions, patients who have multiple comorbidities, and where I'm treating a large area at risk. I think those are great patients to treat. I'm going to stop here so we can have more time for discussion, but I hopefully gave you a sense that to treat calcified lesions, we really need to have a toolbox, and that toolbox needs to include both starting with the right support, using the right lesion modification device, and in order to know which is the right lesion modification device, intracoronary imaging is essential, and then thinking about which of those cases will need mechanical circulatory support. So thank you for your time, and it's always a pleasure to be at TIO.
Azim, thanks so much. That was a fantastic overview, and I would agree entirely with your points. I thought the talk was super clear. The schematic slides of the toolbox were awesome. And let's see if the audience agrees with us, though, with regards to this imaging issue. So we posed a poll question earlier. If we could pull that up now, what the results are, essentially looking at whether imaging is essential for the treatment of lesions. It seems like we maybe have won the crowd prior to these talks, because remember, this was before US's talk. This is great to see. And this is why I have hope, just like you mentioned before, younger generations and times changing, all of you sort of spoke to this, that this is going to tip in the next 5 years for certain. And we'll start seeing more imaging guidance, not only for maximizing your stent results, but also for selection of therapies. One thing I just want to talk about really briefly, because we didn't cover it, it's a nice segue to this calcified lesion segment, is I was impressed with that LAD you showed lot of calcium, long lesion. And I was also impressed that you showed an OCT image, because for most people, if they tried to take an IVUS catheter down that, there's no way it would have crossed in that type of case. So what do you propose, or what do you think investigators ought to do in that situation practically? If you take the imaging catheter, the first tool in the toolbox, and it doesn't cross, what do people do in that circumstance? Maybe Azim, you can answer this one first.
Yeah, so I have a very simple approach to that, and it's the Colombo approach, which is if the IVUS catheter doesn't cross, then you need to rotoblade. So that's my kind of really simple approach when I see calcified lesions.
Yeah, I think you all showed some data in that regard with looking at upfront versus provisional atherectomy strategies, and basically showed that all of the pain points, the duration of the procedure, the contrast, all of those things, even paracedural complications, went up with a provisional approach rather than going up front. Obviously, those cases that you start with balloons and then you fail and have to do atherectomy are higher risk in general, but the principle remains you don't want to be in a situation where you're struggling 2 hours into the case at that point. The other point that I thought was really important but didn't explicitly get said, or doesn't get said that much, is you have to think in these cases. When you have a toolbox as big as you have with the imaging modalities, this is not, I'm going to use my algorithm and just go forward. You have to actually think through these cases, which I think makes them fun. Margaret, when you were in the lab last time, you saw me struggling with a calcified case, and I remember she was telling one of the techs, I love these cases because I have to think. Is that what you find yourself doing? Is that why they're still exciting no matter how much you're suffering during the case?
Yeah, I do enjoy those cases. I suppose it goes hand in hand with doing CTO. The kind of dynamic decision-making element of the job, to me, is what makes it interesting. So I think the algorithms in calcium as well as in CTO are useful for, I suppose, developing a kind of systematic, logical mindset. And then once you've built your experience, it becomes automatic, so you kind of, you get your imaging done if possible, you think about all the options you have available, you try that, see if that works, reassess what you've done, go back around the loops again to make sure you're going to get a good result. And just like Azim said, if you can't cross with imaging catheter, take that information and use that as well to decide how you're going to proceed with the case. So I think it's a useful thing to do early in your training when you're learning how to use all these devices, because it can get quite confusing when we now all have so many options available to us.
Yeah, Didier, how do you train on these? Again, I asked you a similar question with the imaging, but do you learn them all? Do you kind of learn one or the other? Do you need them all? What are your thoughts on that?
I think it has to be some kind of progressive. You need to have a kind of progression when you're learning the imaging, and so the first thing is try to master one of these modalities, and then to move to the other one, because it's not really easy at the start just to be able to clearly understand what you're seeing on the screen. So it requires some proper training. So I would say for the younger generation, it's good to start with one imaging modality, trying to master it, and then move to the other one. And it's the same for the tools. I would say that people think that, for instance, rotablator is a very difficult technique to acquire. I don't think so. I think it's quite easy when you're properly trained, and you should very easily use that atherectomy modality, because it's extremely beneficial for your patient. So it's not for senior operator. I do believe that the fellows should learn that very quickly, and then understand how to use that and to integrate that into the algorithm for complex calcified lesions. So as soon as possible, learn how to use all these tools.
Yeah, I couldn't agree more. And in fact, I think a lot of people, there's a perception out there that only the innovation is happening in the structural space. And that's just not true, because the reality is that in this space, especially recently, there's been more innovation, there are more trials, there's different devices, and at meetings where you can do live training, and even online, you can see different types of devices being used. And that's super helpful, because in your individual practice, although I think, Azim, you showed the pros and cons of one and the other, you'll see that they're complementary. It's not that you can only use one or the other. You have to know how to use a lot of different things at the same time. Joost, tell us a little bit about, oh yeah, go ahead, Azim.
No, I was going to say that, as someone who does both structural and coronary, one of the big differences when you do a TAVR, it's one valve really. to treat, all patients or most patients. And most of my decisions are made before I walk into the room, and then I just execute. When you do a complex calcified case, there's a lot of thinking and changing your strategy and moving a strategy during the case. And I honestly, there's never going to be a single device to treat every calcified lesion. And so you're going to need a toolbox. And, even now with lithotripsy becoming available, it hasn't changed how much I'm doing atherectomy. I'm surprised how I'm doing a lot of rotator shock cases. I'm having to use still both technologies in the same patient. So I think, certainly coronaries have not become boring. I think they're still very exciting to do. And like Margaret and you said, it requires a lot of thought process during the case to do it in a successful and safe way.
Great points. I can tell you that certainly from when I trained through the years to now, some of the cases that we look at, routine referral films, surgical turndowns, if I'd seen those films 5-10 years ago, I would probably be shuddering and saying, oh my God, what am I doing? And now we're doing them and seeing them more frequently just because of these tools at our disposal. Joost, maybe some comments about specific devices and issues about can you do them without on-site surgery? That's important for the U.S. audience, also for some geographies outside the U.S. Are there safety differences? Can we believe those differences? Do we need more data to look at them? What are your thoughts on all of that?
Yeah, that's an interesting question.
So we have a little bit of a sound issue. Well, we'll correct that. Maybe let's see if Margaret or Didier, do you want to pick up on that issue of safety and also on-site surgery and differences between devices?
So I think it's an interesting conversation, and certainly from where I came in the UK before, there were a lot of sites who used all the atherectomy devices in non-surgical centres, and some of that is a kind of system situation. But I think speaking to the US environment, I suppose the availability of IVL maybe brings more comfort in that type of scenario. I'd be quite interested to hear your take on that, Ajay, as someone who's worked in this environment for a while. But certainly I think there appears to be the safety data provisionally from IVL and the published data so far is very reassuring with that regard.
Yeah, I would agree. I think that in general, a lot of it comes down to case selection, though. And what I would say is we do need more data to prove for sure that that's the case, that it is safer to do a low atmosphere inflation and go that way. On the other hand, if you need to shove a guideliner down the vessel and you're dissecting the proximal vessel and doing it, that's not going to be safer. So similarly with atherectomy cases, case selection can help you determine, look, there's no way I'm going to do this case in a place that doesn't have surgical backup. Margaret and I actually saw a case recently where you could just tell it was potentially a really high-risk case. On the other hand, there are other cases that are very straightforward. So once again, it comes back to thinking, and ultimately that's going to be the best way to take care of these patients. I think we're going to move on to the next talk. Joost, we'll come back to you because I know your sound is back. And we're going to have Didier talk to us on multivessel disease and choices of ad hoc staging. Super interesting topic, and I think germane when we see these more complicated patients that we're getting referred to these days.
So thank you very much for this very nice introduction. So let me drive you through the next 5 to 8 minutes towards what we know about multivessel PCI, about the completeness of revascularization, and the need for staging the procedure. So unfortunately, my slides don't run, but it's going to come back. So here are my disclosure. So there are a couple of questions that we need to think about when it comes to multivessel PCI. The first one being, what is the best revascularization modality for a patient with multivessel disease? Do we have to treat the culprit lesion only, or do we need to aim at a complete revascularization if we decide to go for a PCI? And if it's complete revascularization at last, should it be stage or an adult PCI? So these are the very, very important questions that we need to answer before embarking into the treatment of a patient with a multivessel disease. So what is the best revascularization modality for my multivessel disease patient? So we all know now that we have a lot of available literature and guidelines that bring us some arguments to discuss. And we know that roughly, if you want to make it simple, a patient with a multivessel disease and a low syntax score, so namely below 22, and a patient without any diabetes is a good candidate for PCI, multivessel PCI, with the same level of recommendation, 1A, as compared to CABG. So this is the type of global reference when it comes to deciding about the mode of revascularization for our patients. So if we decide to go for a PCI, percutaneous coronary intervention, does complete revascularization matter? Do we have to aim for a culprit lesion only, or do we have to go for a complete revascularization of all the lesions? So I've selected two major studies because there is a lot of conflicting literature from the past available studies, but the two big recent studies that I wanted to discuss with you are first the syntax extended survival study, which is quite interesting because what the authors did was to gather all the patients from the syntax studies. So you can see 1,800 patients, and these patients were randomized compared first depending on the mode of revascularization, PCI and CABG, and second depending on the completeness of revascularization with the residual syntax score, 0 complete revascularization, above 0 incomplete revascularization. So, and they even stratified the patient according to the residual syntax score, 0 to 4, 4 to 8, and then above 8. And that study is very interesting because we can see that in this study, that was a randomized study with a quite high degree of expectation in terms of revascularization. You can see that overall in the PCI arm, close to 60% of the patients had incomplete revascularization. So the information derived from this study are very interesting because the quality of the data and the robustness of the data tells us about, you're going to see what is important, complete or incomplete revascularization. And when we explore that question, you can see if you only focus on the panel A, that the patient in the PCI group with complete revascularization had the same survival, 10-year survival as a CABG patient. So this is really, really important when we decide to undergo to treat the patient with PCI. This has to be a complete revascularization, aiming at the residual syntax score close to 0. If we want to add some kind of granularity to the discussion, what we can see, sorry if yeah, just here, you can see on that slide that in terms of additional granularity, the residual syntax score between 0 and 8 has the same survival as complete revascularization, so as CABG. So if we do PCI, the goal in terms of residual syntax score should be between 0 and 8, aiming as close to 0 as possible. So the second study that you all know that is quite important, the complete revascularization, the complete study, STEMI patient, stratified between the complete lesion treatment only or complete revascularization. And what we learned from the complete study is that If you are facing a patient with a STEMI, when you do a complete revascularization, you have the benefit in terms of the composite primary endpoint of cardiovascular death or new myocardial infarction in favor of complete revascularization. And if you focus on the right part of the slide with the second primary endpoint, including ischemia-driven revascularization, it's once again in favor of the complete revascularization in the setting of a STEMI patient. It's a bit different when we have a patient with a cardiogenic shock, as it is the case with the information provided by the corporate shock trial. You can see that in the setting, in the scenario of a cardiogenic shock complicating an acute myocardial infarction, it's preferred not to go for a complete revascularization because there is a higher incidence of death or replacement therapy for these patients. So different subgroup of patients, different conclusions. Finally, do we have to aim at a staged PCI or ad hoc PCI for patients with multivessel disease? Two studies to guide us through the discussion, because I have to say that this is more about experience and sharing experience and trying to tailor what we think is the best to the patient. This study, that is an observational registry, close to 8,000 patients, 61 US sites, and including stable STEMI and STEMI patients. And this study provided some very interesting insights. The patients that had multivessel disease, including left main, and were revascularized all in the same setting, ad hoc PCI, had an increased mortality. And this is something. This is the first study to demonstrate this type of findings, with a lot of biases. So we need randomized studies definitely in the future to explore that more in depth, particularly in the setting of stable angina. We have data for STEMI patients. For stable patients, this is less well explored. If we come back to the complete study, ad hoc or staged, in the complete study, when the patients were treated in an ad hoc fashion, the median was 1 day. So it wasn't in the same during the treatment of the complete lesion. It was on average a median of 1 day post-procedure. And for the staged patient, it was close to 23 days. I have to say that the patient had per protocol to be treated within 46 weeks, 45 days. So these provide us with a kind of reference when we decide to stage our patients. So just quickly, a couple of examples, because I do believe that ad hoc complete PCI may not be suitable for all patients. So two very simple examples. These are patients that were treated last week at our institution. You can see that the first patient, a patient with an NSTEMI, with a long calcified lesion of the mid-LAD, and associated with a chronic total occlusion of the right coronary artery. So for this patient, you will agree that maybe complete revascularization in the same setting doesn't make sense. What we decided, but this is up for discussion if you want. What we decided was to treat first the CTO of the right coronary artery with IVUS guidance showing a lot of calcium, and so we had to use all the tools that we discussed before, and this confirmed the complexity of the lesions for this patient. So the RCA first, and then the patient came back 1 week later for the treatment of the LAD, once again with the rotational atherectomy, and a good outcome post-stent. Finally, another example, another different patient, the same time of combination of lesion, LAD lesion, right coronary artery lesion. You can see that severe LAD diagonal, mid-LAD diagonal bifurcation with IVUS showing a lot of calcium. Same thing for the right coronary artery, but as it wasn't the CTO, we decided to treat the patient in the same setting with good outcomes, IVUS guidance, as we already discussed, showing a nice MLA at the end of the procedure, both on the right coronary artery and the LAD bifurcation. So to conclude, I would say very simply, that complete revascularization is key for multi-vessel disease, and we have data showing that there is a benefit in terms of survival and the need for a repeat revascularization in the future. A residual syntax score close to 0 or between 0 to 8 should be the target when it comes to analyzing the final results of our PCI. Adult PCI is safe and feasible, and we have data from the trials showing that, but certainly stage PCI could be more appropriate in selected patients, for instance, patients with a renal impairment. So thank you very much.
Didier, that was a fantastic overview, and I really loved how you started with the discussion and decision of revascularization as a whole. It's very easy for us interventionalists to be painted under these strokes of just wanting to do PCI, and that's all we care about. But the reality is the way you started this off by discussing the various revascularization options for patients is the way we actually think about patients, because we're actually physicians first and interventionalists second. And so the findings of what you described in that context are super important. Maybe I'll start with you, Joost, because I know we had that sound issue before. You know, how complete is really necessary if you treat all the left disease and you have a right coronary CTO, maybe moderate size? How often do you feel that you need to push strongly to do that CTO? And I know we have a CTO session later today, but it's a good point of setting a stage at this point.
Yeah. That's a tricky question, Ajay. I think there's a clear difference here whether we are talking about multivessel disease with the involvement of a CTO, or multivessel disease with the involvement of one or multiple lesions with an angiographic diameter stenosis above 50%. So there, I think that also relates to the answer. I think in the latter case, I think it is crucial to consider imaging and physiology in order to determine whether this is truly multivessel disease. Should we just follow our visual interpretation, or should we go for more invasive imaging or physiological assessment in order to get a better appreciation of the multivessel disease? I mean, we learned from Syntax that only in 1 out of 3 patients, these patients that were screened only had 3-vessel disease, where they were all screened as having 3-vessel disease. So I think that attests to the potential of using imaging and physiology. With respect to the CTO, I think there is still a lot to learn on the, let's say, on proper evidence supporting the routine performance of CTO PCI in these patients. In which it seems obvious that if you have a young patient which is in a proper condition, has viable myocardium, that you stage a procedure and do your CTO procedure. Conversely, if you have an 86-year-old with an anterior MI, a proper circumflex, and a CTO of a small RDP, you would probably leave it alone. So I think there's a need for patient tailoring and case-by-case selection.
Yeah, I think the case selection and the thought process is important. Maybe, Azim, a quick comment on that. In the US, we have issues like appropriate use criteria, and you take a totally asymptomatic patient. How do you deal with these residual lesions, whether they're CTO or not?
Yeah, no, it's a real challenge. I've come to learn here in the US. And so, you know, we work very closely with our non-invasive team to try and document a schema as much as possible in these patients. But, you know, it's the challenge I have often is, you know, you treat the left side, the CTO remains, the patient's completely asymptomatic, yet we're leaving this patient incompletely revascularized. And even though there's not enough randomized data for the opening that CTO, there's so much data, like we saw from Didier, that complete revascularization results in better long-term outcomes. I mean, I can't imagine, you know, when a surgeon does a stenotomy and only puts a lima on the LAD and says, oh, no, I'm not going to touch the CTO because it's well collateralized from the LAD, right? And they're always going to try and revascularize as much as possible. And that's partly, you know, why their outcomes are better in some of the studies. But so we've been pretty aggressive in trying to find ways of making sure we can give our patients complete revascularization. But you've been here longer than me, and maybe you can give me and Margaret, who are the newcomers to the US, some tips on how you deal with this.
Well, I certainly don't profess to know the answer, but what I tend to do is up front, when you're making the decision of the revascularization strategy, you talk about what you're planning on doing, not just the first procedure, but the second and sometimes third procedures if the staging is appropriate. I think Didier's points about a multi-vessel ad hoc versus stage were really well taken. But my sense is that I'll have that conversation up front, and provided everything that goes smoothly, then that's how we'll proceed. If there's a complication or something else like that, obviously you may course correct during that time period. And then you also have to take into account the strategy you're going to use. And so if the patient's truly asymptomatic, it's not a huge vessel, are you going to go through an epicardial retrograde to open the CTO? Probably not. So I think that aspect of things needs to be factored into the decision making, and once again speaks to the fact that we need to think about these cases before we just sort of embark upon the revascularization strategy. Margaret, any final comments before we go to the live case?
Yeah, one further point. So coming back to what you said, I think the context is really important. So if you've got an elderly patient with an NSTEMI and you fix the left system and there's a CTO of the right, you should leave that if the patient's asymptomatic. But if you've got a 55-year-old patient who you've taken from the surgeons for PCI rather than bypass, you should completely revascularize that patient. There's no difference between the CTO of the right coronary artery and a 95% stenosis of that right coronary artery if you've got viable myocardium. The only difference is the comfort of the operator in treating that lesion. And if you're not comfortable doing it, you should buddy up with somebody who is and give that patient the equivalent to having a bypass.
Yeah, I would agree completely. And so with that, I think we've had an amazing morning session with didactics and discussion covering issues of imaging, covering issues of calcification, and then multivessel disease, which are really the bread and butter of what we're seeing more and more these days. It's not type A lesions anymore. This is all complex disease, and we need to be able to understand the best tools to treat these patients most effectively and to get them the best and optimal outcomes. So with that, we're going to go on to our live cases. Our discussants are going to stay on as panelists for the live cases. We're going to first move to Mount Sinai Medical Center and then go back and forth between there and Leipzig.